Perfect. Ready whenever you are.
All right. So I'm Tim Bedminster. I'm the pharmacist with the UF IBD program. I've been with the UF IBD clinics for a little over the last 10 years. So I've had quite a lot of experience working with these biologic medications, working with the clinics and providers, and um, working with insurance. It has been definitely a changing landscape over the last 10 years. Things look very different now in terms of the drugs that we use and the methods that we use for prior authorization. Um, so I don't have any disclosures to report. So the goal tonight is mostly just to see, if we can perhaps tease out some ways that perhaps can help with the authorization process, increase access to these medications for our patients, and the dose increases that are often necessary. So we're just going to look at types of insurance, what the process looks like, anything specific to the products, and then briefly discuss appeals as well. All right, so this is, very general, I'm sure. You all are familiar with this, but there's a couple different categories of insurance that we come across in our practice. The first is commercial insurances. These are provided by employers, can be bought off a marketplace. These are through the major companies, Blue Shield, United Healthcare, Aetna, et cetera. We also have government funded. So the Medicare plans, the Medicaid plans, TRICARE, these are all considered government funded insurances. These are a little bit different from the commercial plans in that those plans are unable to use copay cards or financial assistance from the companies directly. So it kind of can make some of these patients a bit harder to get them biologics at reasonable prices. And they also have the uninsured patients. So the thing to talk about, particularly with the government funded, when I talk about copay issues, that's primarily going to be with our Medicare population. The Medicaid plans, they provide the medication at no charge once they go through the process. TRICARE usually has lower copays. So it's that Medicare population that's going to be our hardest to obtain affordable medications for. Though between commercial and Medicare plans, a lot of those coverage policies are similar for biologic medications. All right, so we run into a bunch of challenges with the biologics. First is the formulary. It's always a challenge to kind of remember which plans like to prefer which biologic products, especially if you're moving on to a second or third biologic, and then they'll say, well, we don't want that one, we want this one, and will you consider switching this one? We need a reason for that. So that can be a hurdle that we often have to jump over. Sometimes they have coverage guidelines that quite frankly don't make sense to us as practitioners, where they'll want to try and fail certain products before covering the product that we have decided is going to be probably the most effective for the patient. We come across high copays, co-insurances. Again, we see this mostly with our Medicare patients. However, we are starting to see that now with some of our commercial patients too, where some of these plans are trying to maximize the amount they get from copay cards. So they'll burn out the copay cards near the end of the year, and the patients are stuck with thousands of dollars of copays because the insurance companies won't adjust those prices back down. Something else you might have run into with your infusions, especially if you refer to a hospital-based infusion center, is site of care clauses. Most commercial insurance plans, a lot of their plans do now have site of care clauses for medical provider administered infusions, where they'll prefer lower cost settings at a freestanding infusion center, an independent or a non-hospital based provider's office, or a home care agency. Another issue is preferred pharmacies. It can also be difficult to try and figure out where each insurance company likes to have their prescriptions sent for these biologic products. There are some pharmacies that do offer services, some of these independent specialty pharmacies that will help you find it out. And if they're unable to fill it, they'll forward it to correct pharmacy. But the insurance companies, they like to keep all of their money in-house as much as possible. So they've contracted or own specialty pharmacies to try and keep that revenue. So when working with the prior authorizations, we found it very helpful to just let patients know upfront what potential timelines they'd be looking at. The timelines listed here, just general timelines, with a number of these plans, they may not take that long to get approved. We just want patients to know that this can take time, or it can take an extended amount of time. Once they get all of their groundwork done with their lab testing and everything like that. So we say, we want to start you on adalimumab. Once you get your labs test and they resulted, it can take 2 to 3 weeks in order for us to get it processed through insurance and get it to your pharmacy, where they can then process it and send it out to you. And then for authorizations, something that's very helpful for the support staff is just in the notes, if you have a brief timeline of previous therapies they've tried and failed. Depending on your EMR, this could be simple or difficult to find. But after the initial, like, hey, they've tried like these 4 things, you just kind of add on to it when something new pops up. And then just rationale if you're making a change. We're starting Humira because they tried and failed, et cetera, et cetera. We're going to every week dosing because, of this, that, or the other. So this is essentially what our process boils down to at our institution. We've mostly done away with benefit investigations just because we've worked with a lot of these companies enough that we more or less are familiar with the process. However, a number of drug companies do provide the benefits investigation process that looks into their insurance plan for you, lets you know who to talk to for the authorization. They'll tell you which pharmacy the medication needs to go to. So they can be very, very helpful tools. The downside is that it just adds on a little bit of extra time while you're waiting for all of these. We like to go ahead and start off with the prior authorization request before sending the prescription. We do this just because it helps cut down on phone calls from the pharmacy and from the patient. So if we can just get everything addressed ahead of time and then send the prescription, we find that it usually leads to a smoother process. However, it's not required. If you have a great process going where you start with the medication, send it off to the pharmacy, that's great. It's just what we happen to do. So we initiate the PA request. We like to do this primarily electronically. We'll send the information off to them through Cover My Meds. They provide us with the questionnaire back. We get an approval. We send the prescription. For provider administered products, it's a little bit different. Again, you can do the benefits investigation or copay enrollment ahead of time if that's helpful for your institution. But a lot of the places that we write orders to, we're just able to send them a referral along with the patient's demographics, insurance, and office notes. And a lot of the infusion sites will go ahead and work with the insurance themselves to get those authorizations, so that gets taken off our plate, and then we can assist if necessary if they need appeals, additional questions, etc. All right, so jumping to specialty pharmacies, this is just a quick look at some of the common prescription insurance companies and their preferred specialty pharmacies. I wanted to highlight Florida Blue, Prime Therapeutics, their common one. They do have 2 pharmacies that you can choose from, Accredo or CVS Specialty. One thing to note is that if you're going to do electronic prior authorizations for your Florida Blue members, the prescription will need to go to Accredo. If you do send your medications over to CVS Specialty for your Florida Blue members, or who have Florida Blue for their pharmacy insurance, CVS Caremark does their own special team for Florida Blue patients, and they require everything to be done by fax. So you're unable to call in prior authorizations and do them electronically. If your patient doesn't care which one they go to, Accredo will be the one that's easier to work with from an authorization standpoint, just because you can do the EPA process with them. OptumRx, they work with Optum Specialty, previously Briova. Express Scripts and Cigna merged a year or so ago. That prescription insurance uses Accredo. Aetna and CVS Caremark merge, so that's all at CVS Specialty. TRICARE is also interesting in that you send it to if you're going to be e-prescribing, you would send it to the Express Scripts pharmacy. You would not send it to the Accredo specialty side because the Express Scripts mail order does have a special TRICARE department. And then Humana, regardless of whether it's Medicare or Medicaid, will use CenterWell Specialty, previously known as Humana Specialty. They just rebranded. And Sunshine is also merged with CVS Caremark and Aetna, and but they use Acaria Health. All right, so jumping into some specific products to see if we can try and address some unique issues to each of the medications. One thing to note is a lot of these companies, they want to stay as close to the FDA labeling as they can. So if an FDA labeling says that a patient needs to try and fail a certain medication before this product, the insurance company is more than likely going to hold you to that. This is something that comes up with adalimumab for both Crohn's disease, or I'm sorry. So for both of these, their authorization is just for Crohn's disease and ulcerative colitis. The only restrictions they put on it on the FDA labeling are due to age. That being said, a lot of your insurance plans are going to want to require a trial and failure of a steroid or an immunomodulator prior to approving adalimumab. Unfortunately, depending on the plan, if a patient's been on a 5-ASA medication, they may not consider that enough. Adalimumab is also a self-administered product, so your authorizations are going to be going through the patient's prescription insurance. It comes as a pen and syringe. It's not really going to make a difference to the insurance whether you choose a pen or a syringe. They're basically the same product to them and similar price points, so they're not really going to care too much about that. When it comes to dose escalation with adalimumab, there are some companies that really don't care about it. They're fine with going to once weekly, will not make it too much of a hurdle. However, there are some that it's just automatically going to send you straight to appeals if you're requesting the off-label once weekly dosing. So one thing to note with these dose escalations, and you'll hear me repeat this a number of times, is that the insurance plan is going to place more emphasis on breakthrough symptoms than drug levels. When we have a patient with low serum drug levels, negative antibodies, but they don't really have any symptoms or active disease, the insurance company usually denies those appeals because they see that more as treating the number than the patient. If they don't have active disease, the insurance company doesn't really care as much. So the proactive drug monitoring is something that the insurance company is not necessarily going to be as much on board with. If when doing an appeal and you want once weekly dosing, if there's anything that you can say is a symptom of a breakthrough symptom of their Crohn's or ulcerative colitis, that's going to carry a lot more weight to them. And then if they have low serum levels in combination with that, they'll see that as an additional support. All right, infliximab, one of our golden standard meds. So with these medications, you'll see that the labeling for these require an inadequate response to conventional therapy. It's intentionally vague as to what conventional therapy is. These meds have been around for a long time, and that definition seems to have changed over the last several years. But generally speaking, the insurance is gonna try and keep just that steroid or immunomodulator. Since it does say conventional therapy, some plans are a little bit more lenient with the 5-ASA coverage. Infliximab is a provider-administered product. We like to do it as a buy and bill at our infusion center, or to do it through other infusion centers to process it as a medical expense. Some of the home care companies will process infliximab through the pharmacy insurance and then charge for administration. So there is some flexibility in how this medication gets covered. So it's just a matter of knowing the site that they're getting infused at, how they like to bill. And if it's something that isn't working for the patient, then perhaps a site that bills differently will have different coverage for the patient. For example, if we have a patient that has Medicare A and B and a Plan F Medicare supplement and a Part D plan, then going through home care will likely be expensive because they have to go through the Part D plan to obtain the medication, which will go through their prescription insurance, the donut hole, and all that they can't get financial support for. And then it will be billed for the administration of the medication. However, if those patients go to a buy and bill facility, then the Remicade gets processed through their Part B plan, which covers 80% of the medication, and their Medigap supplement will pick up the remaining 20%, and it represents no cost to the patient. So it's just important to have some sort of idea of how the infusion company likes to bill in regards to the insurance. For dose escalation for infliximab, within certain limits, a lot of insurance companies aren't going to push back too much. Florida Blue does like to push back when it's higher than the equivalent of 10 milligrams per kilogram every 8 weeks. So if they consider equivalent 5 mg per kg every 4 weeks, 7.5 every 6, or 10 every 8. So if you're going above those, that's when you'll get some pushback from them. But generally speaking, a lot of insurance companies are, we don't usually have to go to appeals too often for this medication. There are some infusion sites that aren't comfortable doing the off-label dosing, but that's necessarily an insurance issue. And again, with infliximab, it's more based on symptoms than serum levels for the insurance company. Another thing that we come across with infliximab is biosimilars. It's been a much bigger thing over the last couple of years. The first couple of years was kind of quiet with the biosimilars, but now they've kind of worked their way into more formularies. So some companies will prefer Inflectra, Epsil, or Renflexis over the Remicade product. Unfortunately, there isn't really a great way to ensure that the patient stays on the parent product if they're already established on it, unless they have some sort of history of reaction to it. So that can be quite a battle if you're looking for the patient to stay on a preferred or on a specific product. But starting off, usually the companies will direct you and say like, hey, we prefer this biosimilar over this other product. And then we kind of already discussed the site of care, and insurance can play a role in that. It's just the hospital-based infusion centers are expensive for the insurance companies, so they try to avoid those. We try to use them whenever possible because we have a hospital-based infusion center. But if you're not at one of those sites and you routinely use an infusion suite, a home infusion, or a private office, then this likely won't come into play too often. Certolizumab, certainly one that we see a little bit less often. It has the same vague conventional therapy clause with its authorization. So this medication is also not a first-line TNF in a lot of insurance formularies, so they will try or require adalimumab or sometimes another biologic product before they'll go with this medication. One thing that's unique about this one is that it does come as a pre-filled syringe or as a vial, so you can do it as a provider-administered product. So you can get it to go through medical if the patient does have better benefits in that direction. Dose escalation will always require an appeal, and there isn't a lot of literature about it, but it's something that we do commonly if they're having breakthrough symptoms. And there is some information about it. Another thing to note is that certolizumab is 2 400 milligram injections every 4 weeks. If they are having some amount of breakthrough, you can always try and do 200 milligrams, just one of those syringes every 2 weeks, and see if that more frequent dosing leads to more stable drug levels to help and see if those address any breakthrough issues. All right, so golimumab has a bit more in-depth approval criteria. Let's see, let me move this a little. All right, so you can see it with inadequate sponsor and tolerant prior treatment of continuous steroid therapy. So it's going to be most concerned about steroids. Again, this is not a first-line TNF product. So you'll probably need to go through at least one other therapy beforehand. There is an IV product, but it's not approved for GI indications. So unfortunately, we don't have access to it. Dose escalation with golimumab will also require an appeal. And again, just make sure that you're putting an emphasis on symptoms or making sure to record those. Vedolizumab. These medications will generally require trial and failure of a steroid or an immunomodulator. The nice thing is that there are several insurance companies that will allow you to do this as a first-line biologic, so they won't require a trial and failure of an anti-TNF first, which is nice because we do see higher response rates in biologic naive patients. It's a provider-administered product. And dose escalation for vedolizumab, depending on the insurance company, may or may not require additional authorizations. However, in the case of some, such as Florida Blue, they'll require a patient to have been on it on standard dosing for 6 months before they'll consider an increased therapy. But as long as they've been on it for 6 months, then they are generally fine with the dose increase as long as it's not beyond every 4 weeks. And we've seen that with other plans where we usually don't get too much pushback, especially if they've been established on it for a little while. Natalizumab, not one that we also see very commonly these days. It's important to note that this medication cannot be used in combination with anything else. And the CD Touch program is going to keep more on top of that, the REMS program, than the insurance company is going to. But since it's done through a REMS program, the patient has to enroll in that. Both the provider ordering the medication and the infusion site that's administering the medication both have to be enrolled in the program. So the insurance process is a little bit more controlled and assisted with the Touch program process. So we usually don't come into too many coverage issues with it. It's just making sure that the patient is screened appropriately and that they're enrolled in this program. Ustekinumab has presented some unique challenges just because it has that IV loading dose and then the subQ maintenance. So depending on how you get that loading dose done, you can be looking at 2 authorizations, one for a medical authorization for the IV infusion, and then a second pharmacy authorization for the subQ maintenance. Ustekinumab generally requires steroid immunomodulator or biologic failure before it gets approved. A lot of these companies honestly just prefer adalimumab. That's generally the go-to first line anti-TNF or biologic. But ustekinumab, I have seen it preferred on a small handful of plans. Let's see, dose escalation requires an appeal. And again, just make sure to emphasize those symptoms issues in your rationale or in your note. Risankizumab, we actually are, this fairly new drug for us. We haven't really come into too many issues with it. One of the things is that it just doesn't have a J code yet for those IV loading doses. So we're having issues with some of the infusion sites not wanting to provide this medication simply because it doesn't have that J code available yet for billing. However, we are expecting to get that hopefully soon. The last I heard from the company is that they were projecting sometime in December. Similar to ustekinumab, it's going to have that IV loading dose, subQ maintenance dose. So it's going to have the multiple authorizations. As far as dose escalation, that's not something that we've really come across yet, just because the drug is so new to market. However, it would almost definitely require an appeal, especially since there isn't a lot of information for Crohn's just yet. Tofacitinib, a little while ago, they did place an additional sentence or clause onto their FDA labeling, saying that patient has to have tried one or more TNF blockers. So you are going to see that pretty commonly when these approvals do come through. There are a couple plans that do have Xeljanz or Xeljanz XR as preferred products, but it's generally far and few between, especially because the FDA labeling does say one or more TNF blockers. It's an oral medication, so it makes it a bit more convenient. Insurance companies usually don't care between the immediate release and extended release product. However, a few of them do. I've seen maybe one or two say that they prefer the immediate release over the extended release product. So when it comes to the dosing of this medication, there was also a change in the labeling or in the dosing. So the current one right now is you start off with 10 milligrams BID or 22 daily for a period of up to 16 weeks, after which you are required, or insurance or the labeling says that you must drop down to 5 mg BID or 11 milligrams daily. But if they do have a loss of response, you are able to go back up to that higher dose. So it's generally not going to require an appeal. If you did the loading, you drop down temporarily, document that there is a loss of response, breakthrough symptoms, and then you can usually go back up to that higher dose without too many issues. It requires additional authorization, but usually doesn't go to appeal if you've done that lower dosing.
Hey, Tim, do
Yes.
you at UF, do you know if that's has it been your experience that we have a lot of patients that are on the 22 XR?
Generally speaking, I'm trying to think. I would say we have a number of patients. We
Okay.
usually favor the BID dosing over the once daily dosing.
Okay.
But I would say a good number of our patients that are on TOFA do go up to that higher dosing.
Okay. Okay. I just didn't realize that that was an option. And now that I know that, I will stop using our sample cache. No, that's nice to know.
Oh yeah, no problem. And then upadacitinib, also relatively new for us. ulcerative colitis, similar to tofacitinib, it does have that trial and failure of a TNF blocker. The manufacturers have been aggressive in getting on formulary, so you do see that these are a little bit more accessible. However, I don't think that it is first line on a lot of these formularies. Dose escalation, so it's got 45 milligram loading dose. After that, it can drop down to 15 or 30. I usually go for the 15 first to see if that maintains them, and if not, then increase up to the 30, unless the provider indicates otherwise, just because that gives us some more room to grow. However, if they're really severe, you can just go straight to the 30. You don't need to do that 15 milligram dosing first. Xanamod, another medication that we don't have a lot of, or I don't have a lot of experience with, but generally speaking, it's going to require previous therapies and other biologics prior to coverage. And as far as I know, there's no dose escalation that's commonly used for it. So something that's come across, particularly in the last couple of years, is the idea of combination biologics. This will require an appeal if you ever decide to do it. And you will need some sort of literature to help support the combination that you're looking for. On the bright side, even though we don't have a lot of large clinical trials or high quality literature, there are a number of case reports for a lot of the combinations that we'd be looking for. We've used vedolizumab in combination with tofacitinib, ustekinumab. Right now, we're working on a ustekinumab and combination with tofa and another one with Rinvoq. Those combinations, they do exist. We can get them approved through insurances. We've done it before. It's just they require a little bit of extra work, especially trying to go and find these case reports. So in the event of denial, our appeals, they're usually necessary for the off-label dose escalations, the non-preferred products. We always tend to include patient's disease history, their previous medication trials and failures, and we make it a point to include their current symptoms and how that plays into our rationale for their use. We also include often through primary literature to help support the cases, and generally speaking, we get these approved more often than not. In the case that fails, there's usually a second level appeal, but some plans also offer peer-peers. It's not offered by all plans, but usually when you can speak to someone directly about the case, it usually ends up with a higher success rate, just because you're able to talk about the specific nuances of the case. However, they can be difficult to schedule and coordinate. So I've also included the PubMed IDs for a number of primary literature articles that we use to help support our appeals. Some of these are a bit older because perhaps the issues don't come up as often or people aren't publishing, but we've had success with each of these articles. So I've included these here for you for a number of indications. That also includes there's one of these biologic combination therapy and IBD articles is a review article that tells you where to look for those case reports for those combination biologic approvals.
Thank you so
yeah,
much.
question?
And I'll make sure to share that PowerPoint so everyone can have access to the articles after we're done. But does anyone have any questions for Tim? That was an awesome presentation. Thank you.
I did have one question, Tim. You mentioned that some of these injectable medications can be considered as a provider administered.
Mhm.
And I guess my big question was, I know we used to use that loophole for Stelara, but we're not able to use that
Yes.
anymore, right?
Yes.
Okay.
Mhm.
And I guess to me, it's so arbitrary whether an injection is self-administered versus provider-administered. Like, how do they even make that distinction? It doesn't make any sense to me.
Right. Yeah. So some of it is based on the FDA labeling, because some of it will say like this medication has to be administered by a healthcare professional.
Okay.
In which case it's pretty cut and dry. It becomes more ambiguous when it's a self-administered medication, or medications that are listed as being able to be self-administered. I think the issue with ustekinumab came because they realized a lot of their claims were coming from pharmacy rather than medical, and they're like, it's not worth it. It's you're right. It's kind of a gray area about whether they'll allow it through the medical or not. Some medications it's very clear, but for some of these, such as certolizumab, for some reason it still seems to be able to be given through medical insurance. But even though ustekinumab is a very similar situation, they don't allow that anymore through Medicare.
Okay, so I guess I'm thinking of a specific patient of mine, but I guess for my patients that are on Medicare that are unable to get, Stelara or risankizumab, for example, because it's on the SAD list, they would a good option with them would be certolizumab. Would that be correct?
Yeah. In the same way that Entyvio and Remicade would also be similar options, and that they would get them done through their medical insurance at an infusion site or provider's office.
Okay, perfect. No, that was really helpful. Thanks for including the articles at the end as well. I'm sure everyone will find that helpful as well.
Yes,
Yeah,
thank you. Okay, so I'm going to send out a quick poll to everyone about the next meeting. And then Tim, you can stop sharing your screen whenever you would like. Okay, here's the poll. If everyone could just answer it quickly.